Let me start just by saying that once again, I do appreciate the fact that you are participating in this televideo conference, this webinar, a live webinar. We're doing this, of course, because of the very topic of today's discussion, which is the pandemic that we are currently experiencing, COVID-19. There are many ethical issues that will come up as a result of this pandemic. Obviously, ethics is not the only thing that we need to be thinking about at this time. There are a tremendous number of clinical issues that need to be discussed. There's a tremendous number of economic issues that need to be discussed, organizational issues. And so I don't mean to suggest that ethics is the only thing that we should really be paying attention to right now. However, I will say this, ethical decisions will have to be made. And when those decisions are made, they probably will be made under stress, which means that we will not have time to actually lay back and carefully consider all of our options and to argue about the pros and cons and to be very careful in our moral judgment. That is why we need to think about these things now. We need to think about these questions in advance so that we can, in fact, have some sort of ready response and sort of let our moral muscle memory carry us through when we're making stressful decisions. So I think this is a very worthwhile conversation today. I certainly hope that this is only the beginning of any conversations that we might have to prepare your organization to face the stresses, strains, and difficult choices that are sure to come at us. So I want to start just by describing to you the 4 parts of the talk that we are going to undertake today. Part 1 is understanding the ethical context for many of the decisions that we will discuss. I just want to lay out the landscape a little bit ethically to get our heads wrapped around why pandemics actually do have ethical aspects to them. The second part I intend to keep as brief as I possibly can because I'm not an epidemiologist. I am not a clinician who can bring you any new information about the clinical aspects of what we're experiencing right now. But I do want to take just a few moments to review the current situation and to look back perhaps at an analogy from a previous pandemic in order to consider what sorts of issues might be in the offing. Part 3 is then to get back to the ethics, to pose a series of questions that I think are very important for us to ask ethically. It's a list that I've come up with, but it is not meant to be exhaustive. I'm sure that we will identify new questions today, and we will be able to hopefully have an opportunity to discuss those in the future. And then also part of part 3 is to try to share some helpful analogies. As many of you know, all of you who have been in my training sessions before, I've always argued that the best way to make progress in an ethical analysis is to argue by analogy, to look for decisions that we have made, potentially in less controversial settings, or at least where our judgment has by now become more settled, and to use those analogies to inform our judgment about a current situation which presents issues that appear somewhat novel. And then finally, part 4 of the discussion today will be a review of very specific recommendations. I've been doing work with a number of organizations around pandemic preparedness. Some of this dates back all the way to 2007. So if anyone tells you that we could never have seen this coming, that we had no warning, that who could have imagined such a situation, obviously is not a student of history or has just not been paying attention. Since 2007, there has been a significant amount of discussion about pandemics. I mean, even before that, but I personally, in my own consulting business, have been working on these issues for at least the last 13 years. So none of this should be coming as a surprise to any of us. Certainly, the details of any particular circumstance may be unique, but the general concept that one of the biggest issues that we could face as a society would be some sort of viral pandemic. That is not something that should have taken us by surprise. So those are the 4 parts of the conversation that we want to have, and I'm going to jump right into part 1. In order to sort of set the stage here and understanding the ethical context, to help us sort of understand why there are ethical aspects to pandemic preparedness, I want to introduce you to a concept. or a couple of relevant concepts. One concept that's very important for us to understand is the concept of a moral dilemma. Now, a moral dilemma actually has a pretty specific definition when we're talking about professional ethics. When you're really talking to philosophers about a moral dilemma, that doesn't just mean a morally difficult decision, a moral bind, moral discomfort, but actually the concept of a moral dilemma has a technical usage. A moral dilemma is defined as a situation in which there is a contradiction. There's the existence of contradictory obligations, and that set of contradictory obligations results in the inability to avoid doing wrong. In other words, we have two moral obligations, at least. Let's just stick with two. And they are contradictory, so that the satisfaction of one of them, by definition, involves the failure to satisfy the other. So if you have an obligation to do A and you have an obligation to do B, and A and B are contradictory, you are trapped in a situation where satisfying your ethical obligation A automatically means that you fail to do B, which of course is a moral failing. Likewise, if you choose to do B, then by definition you're unable to do A, and therefore once again you've done something wrong. Now, I do want to point out that many philosophers, and actually I count myself among them, many philosophers don't actually believe that moral dilemmas exist. The reason that many philosophers do not believe that moral dilemmas exist is because we recognize that in any circumstance where you have to make an ethical choice, there may be a need to choose the lesser of two evils. And if that is ethically justifiable, then choosing the lesser wrong becomes not only morally permissible, but potentially morally obligatory, which means that if you do it, you don't actually do anything wrong. Let me give you a quick example. If I'm lost in the woods and I am starving, I have done everything to try to get unlost. I am walking in circles and I don't even know it. I am running out of food and water, and I am on my last legs. It is clear that I am about to die. I cannot survive any longer. And at that moment, while I'm trudging through the woods, I just, by accident, happen upon a hunting cabin. And when I look through the window into the hunting cabin, I can see that lined up on the back wall is a beautiful supply of canned food. And of course, right on the counter is a can opener. So I am elated. I can see that I can save my life. But the cabin is, in fact, locked up tight. And in order for me to get that food, I'm going to have to break a window. I'm going to have to steal the food because this is someone's private property and I do not have any permission to use it. I'm going to steal the food in order to save my life. Did I do something wrong? If you believe in a moral dilemma, you might say, yes, you did something wrong. You have a moral obligation not to steal. You have a moral obligation to respect your right to life and to try to save yourself. The two cannot be satisfied simultaneously, and therefore you're in a moral dilemma. But many philosophers would argue it's not a moral dilemma. And the reason why it's not a moral dilemma is that the right to life is more powerful. It takes precedence over the right to property. I might need to make restitution afterward. There may be moral obligations that then accrue because of the actions that I take. However, stealing that food is something that is no longer morally wrong in those circumstances. Moral dilemma relieved. Now, whether or not we actually believe in a moral dilemma or not, the reason that I spent a few minutes describing this is that I want you to understand that if you think about what a disaster is, a disaster is not just a really bad experience. A disaster is not a situation where, oh, it's tougher than usual. I want to argue that from an ethical perspective, we should be thinking about disaster ethics as situations in which we are as close to imaginable, if not in the middle of, a true moral dilemma. In other words, the decisions that we are going to have to make in a true disaster situation go beyond discomfort that we generally are able to manage. We are going to find ourselves having to make decisions that feel as if they truly do violate core ethical intuitions and values that we maintain. That is as close as we can get to a true moral dilemma. And I would argue that even if a true moral dilemma does not exist, because even those difficult ethical decisions can be morally justified, I would argue that a true disaster is going to be a situation where we will have to make very, very, very difficult ethical decisions that might, in fact, cause us some moral injury. That is, that we may feel moving forward badly about ourselves and whether or not we are, in fact, good people because of the choices we made. Whether you define that as a serious moral bind or as a true moral dilemma, I want to say that that is what we are facing, and that that makes this a very, very serious ethical problem. Now, when we talk about disaster ethics, and I think that we are in one now, it also helps in terms of the introduction to the ethical thinking about this to try to figure out what mindset we should be in. That is, what makes this ethically difficult? What analogies can we bring to bear to help us solve these ethical problems? And so I have generated, and this is just my own thinking about this, a taxonomy of disaster. I believe that there are 5 types of disasters that we should be considering, and I'm thinking of this all through the lens of ethics. That is, that these dimensions force us to think about the ethical decisions we make in different ways. I believe that there are actually 2 dimensions that can impact our moral judgment. One has to do with the source of the problem. That is this human created or is this natural? The other is whether or not this is a discrete event where there is an identifiable beginning, middle, and end, or whether or not this is an extended event that is more amorphous, where we are not sure what the time span will be or even what the geographic impact will be. I believe that these are both important dimensions for us to consider because I think that our ethical thinking is actually informed by these different dimensions. I think that we feel differently about a human-created situation versus a natural situation, whether that is an ability to sort of fix responsibility somewhere, or whether or not we feel a sense of powerlessness. And likewise with regard to the extent of the disaster. Discrete disasters, as hard as they might be, do have identifiable beginnings and ends. They do have identifiable geographic impacts. Extended events are going to create much more stress and likewise much more ethical stress because we're going to have to make decisions without perfect information, where we won't necessarily know the extent of the event. So given those 2 dimensions, I believe there are 5 types of disasters. Number 1, as you can see on the screen, would be a man-made discrete disaster. And a good example of that would be 9/11. It clearly was human-created. It was terrible. Difficult decisions needed to be made. However, there was an identified target or set of targets. There was a specific period of time in which the event took place. And so I would consider that to be a human-caused but discrete circumstance. Compare that to a human-caused but extended event. This would have been a smallpox bioterrorist attack, which our government was very concerned about after 9/11, whether or not we were going to see weaponized smallpox unleashed onto a population. There was a small version of that with some anthrax that really didn't spread. But in those sorts of circumstances, you would still have a human cause, a man-made event, but the impact would be much more extended, and our response would have to be a little bit less well-defined. Now we could also look at number 3, a natural discrete disaster. A good example of this would be something like Katrina, a hurricane. You know there's a storm, it's predicted when it will hit, where it will hit, and then it becomes important to prepare, to manage, and respond. We may or may not be happy with our management, our preparation, management, and response, but nevertheless, those things are easy to plan. They're easy to wrap our heads around. We know when we're in the disaster, we know when it's over, and we can respond appropriately. Compare that to a natural extended event, and an influenza pandemic, or in our case, a COVID-19 pandemic, is the perfect example of a natural extended event. It does not have a human cause. regardless of what conspiracy theories you might have heard out there. I don't think there's any evidence that this had a human cause, and certainly not an intentional human cause. It's natural. It's extended. We're not sure exactly where it's going to hit. We're not exactly sure when it's going to hit. We're not exactly sure how long it's going to last. Now, if we take those two dimensions and we mix them in every possible way, we come up with 1, 2, 3, and 4, and then also number 5, which is mixed, where you could have a mixture of human-caused versus natural and discrete versus extended. A perfect example of that would be an earthquake causes a tsunami, which floods nuclear power plants, and we have the experience of the Fukushima nuclear disaster difficulties in Japan. But I want to go back to number 4, because number 4 really is the granddaddy of all disasters. It is the scariest, it is potentially the most devastating, and it will be the most difficult for us to manage. When we see a disaster of that magnitude, I believe that there are 5 categories of ethical issues that are generated. These are not the questions that I'm going to pose later, but this is just trying to dissect the issue from an ethical perspective. And I think that we can lump our ethical questions into at least these 5 categories. Category number 1, allocation issues. This is what everybody's talking about on the news when they talk about potentially not having enough ventilators to be able to intubate all the patients who are going to need ventilator assistance. So under category 1, allocation issues, I would include questions of triaging victims, that is patients, distributing resources, who's going to receive the scarce resources if we don't have enough to go around. Primarily under category 1, allocation issues, I would include the triage of patients. You will see later on there will be triage questions for staff, but I'm going to include those in their own category. Category 2 of the ethical issues, I would label as liberty type 1. There are going to be 2 different liberty questions. Again, this is going to be based on the distinction between providers of services and basically recipients of service or patients. So the type 1 liberty questions will have to do with things like quarantine, isolation, and what we're now seeing, forced business closures. So what power does the government have to actually limit the freedom of individuals in order to stop the spread of the disease? Should we all go into quarantine? Should identified patients who are positive for the virus be isolated? Should businesses be closed? And should these things be more than just recommendations? In some countries around the world, we've actually had legal consequences for a failure to follow these dictates. We're lagging a little bit behind in the U.S. Some of our states, of course, have said that this is a legal requirement. But I have friends in different parts of the world, and we've been texting, and we've been sort of Skyping, and they actually are facing arrest and fines if they breach these requirements. I don't know that I've seen that happen yet in the United States. Category 3 of the ethical issues to consider is what I'll call liberty type 2. These liberty questions specifically apply to healthcare providers. So they are not the kinds of questions that would apply across the entire population. These questions have to do with things like showing up for work, staying on post, and I would add practicing outside your area of expertise. So to what degree can your employer say to you, you are essential and you have to show up at work? Even though there's a risk of a contagion, we need you. It's an emergency, all hands on deck. If there is, in fact, a corona positive patient on your ward or on your unit, that you have to stay on post and continue to provide those services. And when things really get out of hand and we have a scarcity not just of physical resources, but also of staff, when staff start to become sick and unable to work, can I reassign you to other jobs? And frankly, you might not be comfortable with some of those jobs. So in medical school, there's the old adage, see one, do one, teach one. I'm not sure how long it will take before we pull someone off buildings and grounds and we say, okay, Here's your syringe. It's time to distribute vaccine, which hopefully will be developed before it's too late. Let me show you how to do one. Now let me watch you do one. And now here are 3 people. You go off and show them how to do it. Standards of care within a disaster are going to change radically. We need to be prepared for that. Under what conditions do you have the right to simply say, no way, I didn't sign on for this, I'm not trained for this, I'm not interested, I won't do it? That's Liberty Type 2 questions. 4th category of ethical issue, fairness. This is different than the allocation issues that I listed under Type 1 that were much more patient-centered. Now I want to think about fairness issues with regard to providers of healthcare. How do we distribute risk across those healthcare providers? Is it ethical to concentrate the risk in a small number of people in order to hopefully maintain a reserve of providers for a later time? Or is it more fair to distribute risk across all providers, everybody taking their turn? There are efficiency questions in both directions. How are we going to triage staff? How are we going to provide and distribute personal protective equipment to staff? Who should the highest priority staff members be? And how are we going to make those decisions? Those are all the fairness issues that I list as category number 4. And finally, category number 5, public coordination. When I first wrote this slide way back in 2007, I almost contemplated moving number 5 way down to the bottom of the slide because I thought, well, I'm not really sure if that's an ethical issue. Maybe it's really just sort of a logistical issue. Surely there will be good public coordination in the event that we face something like a true pandemic. I am moving this back up because, frankly, I do see this as one of the biggest ethical questions, and it's not at all clear to me that we are receiving sufficient guidance from a centralized source of authority so that efforts at managing this disaster are properly coordinated. Who's in charge? Who makes decisions? Why are we relying on college presidents and presidents or team owners in the NBA to start deciding when things should be canceled? Why do different governors have to bid against one another for PPE because we don't have a centralized supply system? Is it every state for itself? Is it every hospital for itself? Is it every health planning region for itself? We need public coordination. We need to know who makes these decisions. My own community, I am sure that the superintendent of schools believes that she's in charge of certain decisions, that the CEO of the local hospital system believes that he's in charge of certain decisions, that the city manager believes that she's in charge of certain decisions, and that the police chief believes that he's in charge of certain decisions. This is untenable. We need to know that there is a coordinated response, and I do believe there's an ethical aspect to that. Let's move on to part 2. And I'm going to keep this as brief as I can. We only have an hour together, and I want to make sure we get through all of the ethical issues. But let's just do a brief review of our current circumstances. As I said earlier, of the 5 types of disasters that I can imagine, and I'm imagining when I say types, again, it's through my ethical lens as to the kinds of questions that will be raised and the senses of responsibility that will be triggered. I believe that the scariest of them all is type 4, the natural extended disaster, a pandemic. We do have examples of this. If we look back at 1918, and again, I'm not here to lecture to you now about all of these details because I'm an ethicist, but I just want to go over this very, very quickly. A pandemic is defined as a situation in which the entire world population is exposed. In 1918, 40% of the world's population became symptomatic and 4% died. The pandemic actually made 3 circuits around the globe where we were exposed to it 3 different times over an 18-month period. So if we think that this is once and done, if 1918 is our model, we will be mistaken. We need to be prepared for a second wave in the fall, a third wave next spring, that this could spread out over a year and a half as northern and southern hemispheres each experience their own season of contagion. And I will also point out that the first wave in 1918 was not the most deadly. The second wave was. So we do need to be prepared that this could get worse. In 1918, young, healthy people were hardest hit, some becoming ill in the morning and dying that night. And fortunately for us, that does not seem to be the case with COVID-19. Young people certainly are susceptible. They are getting sick, but they seem to be surviving the illness at higher rates than the elderly and those with underlying health conditions. Now, we are better off in some ways than we were in 1918. Our healthcare system has significantly improved, including the development of antibiotics and antivirals. I remember a lot of deaths from something like this come from secondary infections and healthcare overload. We also have life support technology that we did not have in 1918. Those are all good things. Also, our communication systems are vastly improved over what we had in 1918, which means that if we can, in fact, mount a coordinated response, we have the tools, the communication tools at our disposal to make that happen in an effective way. But don't get too excited. I think that we have significant disadvantages as compared to 1918 that make us at least as vulnerable, if not more vulnerable, than we were as a population back then. Our population is much more mobile than it was before, which means that the spread of the disease can take place much more quickly. Our modes of transportation are also much more likely to spread contagion. We have lots of people on airplanes and on trains breathing on each other and being in close proximity. Big airports, big train stations. Many more people live with immunosuppressive illnesses or treatments. So they didn't exist in 1918. And now, thanks to modern medicine, people are able to live for extended periods on immunosuppressive therapies or suffering from immunosuppressive illnesses. But they will be at great risk from this contagion. And one of the things that, for me, is the scariest of them all is the fact that our supply lines for food and other essentials are far longer and more tenuous than they were in 1918. My guess is that in 1918, most of the food that a person ate came from within 100 miles of where they lived. I believe that most of our food now comes from thousands of miles away, and those supply lines are going to be difficult to maintain. In addition to that, we have, I think, intentionally cut reserve supplies out of our economy in important ways. We have adopted, I think in order to maximize profits in our system of capitalism, had just-in-time inventories. Any inventory you hold was money you weren't making. And so we've created an economy that was designed on the fact that your store would run out of what it needed just as the next truck is arriving to replenish the stock. That's true of food and supplies, and now we're finding out healthcare resources such as PPE and, for that matter, hospital beds. We don't have surge capacity. That is a risk. Now, if we were to take the 1918 numbers, 40% ill, 4% dead, and simply map them onto modern Virginia, where we now have 8.5 million people, that would mean that over an 18-month period, we'd have 3.4 million people sick, 340,000 people dead, on top of the background death rate. We'd have 18 months of no movies, no shopping, no economy. We have to worry about who drives the trucks, who buries the dead, who runs the hospitals, who goes to school. This is a significant challenge. It's not clear that our economy can actually survive this. This reality creates an ethical set of questions. Just to quickly map that on to 2019, we're dealing now, as you all know, with a novel variant of the coronavirus, which is responsible for the common cold, but this is a novel version. About 82% of those infected suffer only minor symptoms. This is a dangerous version of the virus, triggering a hyperimmune response and suppressing cilia action so that you have trouble clearing the mucus out of your lungs. It does not seem to be prevalent in the pediatric population, which is a good thing. The incubation period seems to be 2 to 14 days, although some studies indicate it's possibly longer than that. As of this morning, and these numbers are already no good, there were 351,067 reported cases worldwide with 15,337 deaths. In the United States, there were 35,075 cases reported confirmed and 458 deaths. In Virginia, we had 219 confirmed cases and 4 deaths. But just before I signed on here, I checked the news, and we now have 6 confirmed coronavirus-related deaths in Virginia. We also now know, just from the last hour or so, that the governor of Virginia has imposed a 30-day moratorium on any non-essential business a prohibition on gatherings of 10 or more, and that schools are now canceled for the rest of the year. So a 30-day order has gone into effect as of today from the Virginia governor. Just by context, in case you want to read this slide later, I'm not going to go through it in depth because, again, this is more technical than it is ethical. MERS has an R naught, that is a contagion rate of less than 1. So every one person who has it passes it on to less than one additional person. For fatality rate that's very high, 34.4. Seasonal influenza has an infection rate, an R naught of 1 to 2, and a fatality rate of about 0.1%. SARS has an R naught of 2.75, so every one person who gets the disease is likely to pass it on to 2 3/4 additional people, with a 9.6% fatality rate. Measles, notice how dangerous this is, an R naught of somewhere between 12 to 18, with a 15% fatality rate. Imagine a new version of measles now. If we didn't have a vaccine for that, it would be horrendous. COVID-19, by comparison, has an R naught of somewhere between 3.28 and 4.08, although those numbers are older, and the latest numbers based on studies from the Diamond Princess, the World Health Organization is bringing that down to somewhere between 2.28 and 2.5. Fatality rate is extraordinarily difficult to calculate because we don't have enough testing. So if we don't have a denominator, we can't divide the total number of cases by the number of dead, and therefore it's very difficult to assess the fatality rate in the United States. An estimate of the 1918 influenza pandemic placed its R naught at between 1.4 and 2.8 with a fatality rate of 10%. That might be very, very similar to what we're dealing with here with COVID-19. Now let's get into the ethics of this in greater depth. What we want to do now, and I'm just seeing a note from Julianne that she's asking you to email any questions that you have. So we're about to get now to the ethical questions, and keep those emails going to Julianne, and I'll pause when I'm done running through my PowerPoint in order to see what sort of questions you have. But let's just look at a series of questions. And these are just sort of brainstorming questions. These aren't even particularly ordered in terms of priority, although I did break them into 3 groups. The first set of questions has to do with broad societal questions. These are the kinds of questions that, quite frankly, in any particular healthcare setting, we will not have the authority to make decisions about these sorts of things. So let's just list them out. 1, who should be in charge of coordinated response efforts? As I noted before, I used to think that was a low-level question. I'm moving it up to the top because I'm just not sure that we're thinking carefully enough about the need for a truly coordinated effort. 2, under what conditions are mandatory quarantines ethical? 3, under what conditions are mandatory business closures ethical? 4, is it ethical for healthcare facilities forcibly to commandeer private or public businesses or educational infrastructure and other resources? In other words, at what point does the local hospital get to say to the high school, we're taking over your gym because we need to have a unit there. We need to set up a field hospital. We're just taking it. 5, is it ethical for the pharmaceutical industry to suspend human clinical trials or otherwise adjust protocols in order to rush a vaccine into production? 6, would it be ethical to compel vaccination? If we do have a vaccine that gets created, is it ethical for the government to force everyone to be vaccinated? And that becomes even more problematic by asking question number 7, would it be ethical to compel vaccination with a vaccine that was developed under adjusted safety and efficacy testing protocols? In other words, it's one thing to say we have a tried and true vaccine, and it has been tested for efficacy and for safety, and now we're going to require that everybody have it. I believe that New York State did that during the recent measles outbreak. But if we adjust our standards for testing, does that change the government's ability to require that people accept a vaccine that may not have been tested to our normal standards of safety or efficacy? Those are general, broad societal questions that I don't think we have the authority to answer. Let's switch then to facility-specific questions that, frankly, your staff will have to consider. 1, may staff members refuse to come to work? And of course, that's not just a yes or no question. It would have to be, and under what conditions? If you're going to allow that to take place, what are those conditions? 2, do staff members have a right to refuse to provide services to high-risk patients? So how are we going to manage the patients who have tested positive? And do staff members say, I am more than willing to do certain types of things, but I'm not willing to do others? 3, do patients have a right to refuse services from high-risk providers? We don't often hear this question. In fact, I haven't heard anybody ask it yet. But if a patient goes to a hospital, if you have the right to test me before you're going to be around me and provide me with care, do I have a right to see your test results before I let you near me as a provider? Do I have a right to choose my providers? 4, should rotation of dangerous staffing assignments take place to reduce the risk of contagion, or should all staff members take their turn? Should some staffing assignments be sequestered from contagion so that non-pandemic related treatments can continue during the high-risk period? In other words, what we might need to do if we want to maintain a continuum of care is to actually take some healthcare providers and explicitly make them non-COVID providers so that they can do many other sorts of things that we won't be allowing our COVID positive healthcare providers to do. 5, should staff who have elevated risk factors be excused from hazardous duty? 6, should staff members' family situation impact staffing decisions? So is it ethical that if you have young kids at home and you are the sole breadwinner for the household, that you don't have to do dangerous work, but the person who never met the right partner and no one likes anyway and is just sort of a loner, well, let's just take the loner and put him on hazardous duty. Is that an ethical way to do this? Should social circumstances contribute to decisions about who is going to be placed at highest risk? 7, may staff members be quarantined while working? This is an important decision, an important ethical question that also is going to have to follow CDC recommendations. At first, the CDC was recommending that anyone who is suspected positive must go into a self-imposed 14-day quarantine. I don't believe that's going to be tenable. Doctors are going to start getting sick, and we're going to run out of doctors. A good number of those doctors will be sick, but not seriously ill. At what point does it become ethical to say, we are going to create a unit of COVID positive patients, and we are going to take COVID positive providers who are still well enough to actually work, and we're going to have those providers deal with those patients? Quarantine while working is something I've not seen anyone really talk about, at least not on the national news programs, and I think we're going to have to consider it. 8, do any particular staffing assignments exempt an employee from hazardous duty? Are there essential functions that need to be protected? Those are not just healthcare functions. The guy who knows how to keep the computers up and running, that's extremely important if we're going to be able to do what we need to do as a healthcare organization. Should that person get special protection against contagion in order to make sure that the lights stay on, if you will? 9, how should we compensate those at greater risk? That is, do people deserve hazard pay? 10, how should we prioritize recipients of personal protective equipment or vaccines? When we finally, well, now we have PPE, N95 masks being the big piece of equipment, but gloves and masks and gowns, how should we prioritize who receives those? And when a vaccine does come online, and will likely come online in small amounts, at least to begin with, when there's a shortage of the vaccine, who should get it first? 11, how should we prioritize recipients of scarce treatments? Of course, we all think of intubation, but in many healthcare circumstances, for instance, in a mental health institute, you're not going to be deciding who gets intubated and who doesn't. However, once the local hospital is being overloaded, they're going to want you to triage patients before you send everybody to the hospital. That means that even in a secondary or tertiary healthcare environment, or a specialized healthcare environment like a mental health institute or a long-term care community, the decision about who gets intubated and who does not actually will probably take place further away from the hospital. Those patients will simply not be sent to the hospital, which means we are going to have to deal with that across the continuum of care. 12, when does it become appropriate to restrict visitation? This should have been an easy one, but I'm afraid that we did not get this one decided quickly enough. When the World Health Organization declared a pandemic, it was time to stop visitors, period. I'm not sure that enough hospitals actually did that. 13, is it ethical to house suspected COVID-19 positive patients with known positive patients when space is limited? This is going to be a question about how we actually rearrange where our patients are living in order to try to stem the spread of the disease. In addition to the facility-specific questions, there are going to be some questions that are at the intersection of sort of broad societal discussions and facility-specific questions. They're going to have components of both. Here's a list of some of those. 1, should broader social considerations impact local decisions? That is, at some point, we are going to have to make decisions about the allocation of scarce resources, and broader social considerations might actually come into play. Who gets to make those decisions, but then who has to carry out those decisions? Are we going to provide ventilators to people who are younger? Not because old people are generally at greater risk. That would be a perfectly legitimate clinical consideration, that if you're less likely to survive, you should be a lower priority recipient. But at some point, are we just going to say, you know what, saving a younger generation is just more worthwhile? I don't think that a hospital gets to make that decision. But once a decision like that is made on a higher social level or governmental level, we're going to have to carry it out. And we're going to have to ask if we're willing to do that. 2, how should admissions criteria change in the event of a local outbreak of a pandemic? That is, you may not need to come to the hospital. Should we no longer allow you to come even though you historically would have met admission criteria? In terms of a mental health institute, I'm thinking about this specifically with regard to your inability to refuse to allow any TDO to come into your hospital. Do we need to adjust what we consider to be admissions criteria, knowing that risk might go up for people who remain in the community, but frankly, the risk associated with coming into a congregant living setting like a hospital could be far higher? Should we not be admitting people that we would have admitted 3 months ago? There's a flip side of this question. How should discharge criteria change in the event of a local outbreak of a pandemic? That is, should we be pushing people out of the hospital who are already here because A, we need the beds for people who are sicker, but think about this in a slightly different way, because the risk of hospitalization itself goes up during a pandemic. So think about the psych patient who comes in, meets criteria for inpatient acute care hospitalization because this person suffers from psychotic illness, paranoia, and is locking himself in his apartment and isolating himself from all of his social contacts. It is based on his paranoia, it is not healthy, and he is coming into your hospital, he came into your hospital because you felt that you could provide him with some significant benefit. Frankly, that's exactly the kind of person who will do better now in the community than they will in a hospital. The fact that they will self-isolate secondary to their paranoia is actually a good thing during a pandemic, and provided that we can find a way to make sure that their ADLs are met, that they can feed themselves and bathe themselves and clothe themselves, they're probably at much greater risk living in a hospital, getting psychiatric services, than they would be living at home and getting those psychiatric services either through tele-psych medicine or by some other way. Question number 4. Does a healthcare organization have an ethical obligation to share resources with harder hit localities or facilities? We are already seeing this happen because some of the facilities within the Department of Behavioral Health have more resources in terms of N95 masks, or actually the specific question is testing equipment for the N95 masks. That is the fitting equipment. You need the solution, you need the hood, and then you need the masks. If you don't have the solution to do an N95 fit test, but another one of your sister facilities does have that, do they have a moral obligation to share with you, or are you on your own? 5, does a patient's non-compliance with recommended precautions result in his or her forfeiture of the right to access scarce medical resources. So if two people come to the hospital, they both need a ventilator, and there's only one vent. One of them self-isolated, took all precautions, but somehow managed to get sick anyway. And the other one, we have video of them gallivanting on the beach in Florida during spring break saying, "This is all stupid." Does the person who took that voluntary risk to health forfeit his or her right to access the scarce medical resource? Or if it's not a complete forfeiture, do they have a lower priority? Does a doctor have to put herself or himself at risk to provide services to someone who knowingly disregarded healthcare recommendations? Under normal circumstances, the clear answer to this question is no. Voluntary risks to health do not reduce your ability to claim healthcare resources. We don't say no to lung cancer patients because they smoked. We don't say no to HIV positive patients who shared needles. We do say no to alcoholics who drank their livers into oblivion when it comes to transplant, but not if they no longer drink. In other words, there's nothing punitive about it. There's no backwards looking discussion about, well, you ruined your last liver so you don't get another one. What we do say is, if we have reason to believe that you are going to be non-compliant in the future, such that you will not have success with this resource, then we'll say no to you. But there's a huge difference between putting someone at a lower priority because we don't believe that they're likely to benefit from the resource, as opposed to saying you don't deserve the resource because of the choices you made previously. Question number 5 deals with that latter question. 6. How should we manage patients with diminished capacity who refuse to be tested for COVID-19 when the process for obtaining a court order for treatment over objections takes time? In other words, especially in a setting like a mental health institute, if you have a patient who just says, nope, don't want the test, what rights do they have to say no? And do you need to jump through the hoops of getting a special justice to sign off on forced treatment before you can do the testing? 7. Do patients have a right to refuse to be tested for coronavirus? And if so, how should they be treated? So this is the broader version of the previous question. Not just do we have to wait to get a court order, but can we just take that right away entirely? Can we just say, I'm sorry, under these circumstances, you don't have any right to say no. We're not going to go to a court for that. We're just going to swab you. 8. How should organizations make decisions about and provide support to employees who are furloughed during this crisis? There are actually multiple aspects about organizational responsibility to employees. The most obvious is making sure they have PPE and taking care of them. We'll come to some of those recommendations in a moment. We also need to wonder about economic impacts and to what degree do we have a responsibility as an employer to look out for the needs of our employees. I'm going to keep moving here, and I'm going to move very, very quickly through this section. I simply want to share with you 3 analogies that I believe can help sort of index our moral thinking about this. As you know, as I've always taught, I believe the most productive way to make a moral argument is by analogy. Find a situation that is similar enough that it gives us some guidance to the degree that we can transplant our moral intuitions about those easy cases to the more difficult cases. Of course, every analogy breaks down at some point, so arguing by analogy is just a start to sort of wrap our heads around the moral aspects of any particular situation. Nevertheless, it is the core of a good casuistic bit of reasoning, and I offer 3 analogies now. The first analogy, you will remember that I have done some training on active shooter response, and that we now have guidance from law enforcement that says that in an active shooter situation, you should run, hide, and fight. And what you might remember from a previous educational session is this slide, and specifically the picture in the upper right-hand corner. Run, hide, fight is the new mantra for how we respond to an active shooter. And you see in the upper right-hand slide 4 clearly healthcare providers, because they're in scrubs or they're in white gowns, running away. We had an extensive conversation about this in previous educational sessions, and we asked, does a healthcare provider in the face of an emergency have any special ethical obligations? Do healthcare providers have any special ethical responsibilities towards the individuals whom they serve? Do healthcare providers have an obligation to put themselves at elevated risk in order to protect the individuals whom they serve? How extensive would a duty to protect clients be? If you remember when we talked about active shooters, we started with an even more familiar analogy. What does our current emergency response plan say about a fire in a building? Do healthcare providers get to just run away? Or do healthcare providers first have to try to secure the patients and then try to evacuate the patients and then worry about themselves? In a fire situation, you can't just run away. In a blizzard situation, you can't just run away. You do have to put some level of concern in place regarding your patients. If you recall, what we said about active shooters was that we might need to adjust the mantra to say, help, run, help, hide, run, hide, fight. In other words, you can't just run. You have to start by helping your patients run. If your patients can't run, you have to help them hide. And then at some point, if you can't do anything more, you need to worry about yourself, and then you need to run, hide, fight. That leads us to analogy number 2. And I presented this case a number of times. I won't go through it in depth, but I had this ethics consult years ago about some home health nurses who went to provide care in someone's home and fell through the floor. The problem with the floor was well known, well documented. Efforts had been made to help this woman move. Efforts had been made to offer her the opportunity to fix the floor. She rejected every one of those options. The floor is now falling apart, and the home health nurse said, "We're not going back." We got an ethics consult because the supervisor said, "That's part of your job. You have to go back." By the way, our ethics consult said, no, you don't. There are limits to your responsibility. So if the first analogy says, look, as a healthcare provider, you do have to place yourself at risk. You do have responsibilities to the patients whom you serve. This second analogy says, but there are logical limits to that. I think we can conclude some roles do require reasonable levels of sacrifice. Police have to put themselves in harm's way to fight crime. Firefighters do put themselves in harm's way in order to fight fires. Home healthcare workers walk into homes that are disgusting and get covered in bed bugs and cockroaches and all the rest of it. That's built into the job. However, there are limits to that responsibility. Police officers are not expected to make themselves into human shields. Firefighters are not expected to run into known collapsing buildings. They may do it, but they're not required to do it. Home health providers would not have to go into a crack house and provide health care in the environment where it's extraordinarily dangerous because dangerous illegal things are happening. Additionally, employers must make reasonable mitigating efforts. We have to provide bulletproof vests to our police officers. We provide fireproof suits to our firefighters. We need to provide PPE to our healthcare providers. These three concepts actually do fit together. As providers, you do have to make some reasonable sacrifice. You can't just look out for yourself. You took an oath, you need to follow through. There are limits to that oath. You're not expected to just lay your life down. And your employer needs to make reasonable efforts to try to protect you as best as they possibly can. That leads us to the third of our three analogies. Allocation of scarce resources. Remember this case that I have presented on a number of occasions. You have two people who come in, say, to the CSB for services, and you only have one slot. One person comes in first, the other person comes in second, but the person who comes in second has no other resources available, could not have their needs met in any other way. The person who arrived first does have alternatives. We have argued repeatedly that there are the 4 E's of scarcity when we're making allocation decisions. How efficient are we being? Are we making sure that we're getting the biggest possible return on every dollar of investment or resource investment we make? How effective are we being? Are we actually achieving measurable positive outcomes for the people who are actually benefiting from our efforts? Are we treating people equally That is, do we give everybody an equal amount of the resource in question? And most importantly, I would argue, are we being fair? Are we being attentive to the concept of equity? And as you'll remember from earlier educational sessions that I have provided, I would define equity in the following way. A maximally equitable distribution of goods or services is that which minimizes harm to the non-recipient of resources or services in question so as to bring about the least harm to the least advantaged recipients. When we consider equity, we apply the economic principle of maximin, obtaining the best possible worst-case outcome. In other words, in a true disaster, we are not trying to get the best possible outcome. We're not even necessarily trying to be as efficient as we can with our resources. I can tell you that the most efficient thing to do with an N95 mask is to treat as few people as possible with it, because a lot of those people are going to die, and your success rate will go through the roof if you compare the resource applied versus the return on investment. But we are here to save people, and sometimes that's not an efficient thing to do. Equality has no place here at all. Equity is where we need to go. A fair approach to rationing is one that seeks to maximize benefit to the least advantaged member of the group. Once minimum standards are met for everyone, additional resources should be used to improve the situation of those who are least advantaged. Rationing a public resource is morally justified if and only if, one, there actually exists a shortage of the resource in question. So until we have a shortage, we should be trying to help everyone. Two, an identifiable victim of a failure to ration exists. In other words, if you do nothing, someone is a victim, someone loses. And the victim of the adopted rationing scheme is disadvantaged less than the victim of any other rationing scheme, including the lack of rationing altogether. This would work in the direction of using our scarce resources in order to help the people who are capable of achieving good results if they get the resource. If you're going to die, even if you get the resource, then you have no claim on that resource. And it is not true that first come, first served makes sense here, because we are not trying to treat everybody equally. We're trying to see to it that the worst case outcome that we can imagine is better than the worst case outcome we could have achieved through any other possible choice. In an environment of true scarcity, our goal must be to minimize the harms done rather than maximize the benefits received. When allocating scarce resources, our only constraint on the lower end is to satisfy minimum standards of care, and those minimum standards will be radically different during a pandemic. Here's the central ethical concept, and I'm almost ready to sort of wrap up with some recommendations. If you go all the way back to Aristotle, you know I'm not big on theory, but if you go all the way back to Aristotle and talk about virtue theory, he always argued that you could define the moral obligations you have by understanding the role you play in life. Aristotle would say, always act consistently with the standards of the role you play in life. Tell me the story of your circumstances, and I will know what I can reasonably expect from you. That is something called your arete. The arete is the virtue. You are a doctor by virtue of the fact that you, fill in the blank. You are a nurse by virtue of the fact that you, fill in the blank. You are a social worker by virtue of the fact that you, fill in the blank. What is the essence of your role? Once we understand your arete, the essence, the essential character of what it means to be the kind of thing you are, we will know what we can expect from you. The point, however, is that disasters bring altered standards of care. We need to communicate clearly about the changes in standards of care so that we can match people's expectations to what actually is going to happen, and you will not be held responsible for a standard of care that does not apply when it realistically cannot apply. That gets us to very specific recommendations. I am not going to tell you that all of these are absolutely correct, and I'm not going to tell you that they apply in every circumstance. What I will tell you is that these recommendations come from work that I did just this past week with an ethics committee trying to grapple with these specific types of issues, and by the way, specifically in a mental health setting. Here are, I believe, the 15 recommendations that this ethics committee developed. This is just a quick summary statement for each. The document we created actually contains greater detail for each of these recommendations. 1, the facility should advocate actively for statewide coordination of the pandemic response. We need to make sure that a central office is coordinating efforts across facilities. More importantly, that the state is coordinating efforts across departments, and for that matter, that states and the federal government are coordinating amongst themselves. 2, in the absence of a coordinated plan, it is not unethical for the facility to restrict its efforts to its own facility. In other words, until there are marching orders that tell you how you are going to cooperate with other facilities, it is not unethical for you to be worrying about your own facility. That does not mean that you can't cooperate with others, but it does mean that at this point, you need to be worrying about what's in front of you and let other facilities worry about what's in front of them. As I said in number 1, we should be advocating for a centralized response, but in the absence of that, we should be worrying about our own needs. 3, the facility should follow all laws, protocols, and clinical guidelines that are promulgated by the CDC, the Virginia Department of Health, and state and federal authorities. We get all kinds of mixed messages coming out of all different sorts of sources. It's very important that the facility should feel an ethical obligation to apply appropriate clinical standards of care. 4, the facility should recognize that standards of care must change during a pandemic and that it should communicate clearly about these changes in order to avoid confusion about reasonable expectations, both as providers and as recipients. This is the Aristotelian point. It's very, very important for people to understand that what you could have demanded from your hospital yesterday is different than what you can demand today, and that does not mean that the hospital is doing a bad job. 5, consistent with the previous recommendation, we suggest that alterations to normal operating procedures should be considered in a number of areas across all departments and disciplines, such as, but not limited to, visitation, elimination of group activities, relaxation of documentation standards, alteration of the risk-benefit calculations that would typically prevent the use of alternative methods to allow patient access to family contact, and efforts to reduce the number of patient contacts. I do want to provide just a little bit of more detail on this particular recommendation because the Ethics Committee, in this particular case, specifically talked about constraining visitation, eliminating group activities, whether they be therapeutic or recreational, relaxing documentation standards for clinical and non-clinical staff when continued efforts to provide complete documentation conflict with the ability to provide services efficiently. Alteration of the risk-benefit calculations that would typically prevent the use of alternative methods to allow patient access to family contact, such as cleaning phones in between patient use, even if that might create a choke hazard on the unit, and relaxing confidentiality requirements regarding video conferencing with family members. Also, efforts to reduce the number of patient contacts should be put in place, potentially discontinuing 30-minute checks for low-risk individuals, reducing intra-unit transfer of staff, increasing physical separation of patients, such as by altering dining schedules. Moving on to recommendation number 6. The facility may consider offering increased compensation to employees who are placed at elevated risk, but doing so is not ethically obligatory. So hazard pay is something that could be considered, but what we don't want to do is send the message that without hazard pay, you don't have to show up for work. You're still an essential employee, and therefore hazard pay can be just discussed later. It does not actually impact whether or not you have a responsibility to come to work, which brings us to recommendation number 7. In a declared emergency, it is ethical for the facility to designate all employees as essential and require that they come to work and stay on post. Exemptions may be made for employees who have a demonstrably high risk factors or a high risk family situation. 8. It is ethical to distribute work assignments in order to maintain high efficiency throughout the duration of the crisis, which might require protecting some employees from contagion. This might also require some employees to work outside of their normal duties or areas of expertise. In other words, equal distribution of risk is not necessarily sensible in this case. it may make sense to make sure that certain specialties that are unique and where we would be at a great loss if those providers were not still capable of working, that people who do those unique sorts of jobs are going to be sequestered and protected from contagion. 9, the facility should aggressively investigate alternate service modalities in order to reduce overall risk. We've talked about some of those. Greater reliance on telemedicine, greater reliance on social networking for families to visit with their loved ones, etc. 10, it is ethically appropriate to consider segregating patients based on their disease or suspected disease status or potential exposure. We can't get into too much detail here because it's a clinical decision rather than an ethical one, but basically it would not be unethical to have tiers of housing for COVID positive, for COVID suspected, for general population. It would be a clinical decision to decide how to segregate patients into different groupings. 11, in the current circumstances, it is ethical to force COVID-19 testing over patients' objections. We believe that that this is an emergency situation and that therefore emergency standards should apply and that we should be able to provide services without getting court orders without delay. So I do not believe that patients have the right to refuse to be tested. 12, rationing of personal protective equipment, antivirals, vaccines, and other protective modalities should place first priority on direct care providers who are at the greatest risk of infection. Second, on individuals who are at high risk of contagion and who are likely to benefit from receiving the resource. Third, on individuals who are likely to benefit from receiving the resource but are at a lower risk of infection. And finally, on the basis of random selection, first come, first served, because we do not believe that the facility should rely on any criteria that are not related to the clinical indication or efficacy of the particular item being rationed. To explain this, just to be clear, first priority needs to go to providers who are at great risk of infection. Otherwise, we lose the ability to provide services at all. Second priority will go to either providers or patients. This is a mixed class of those who are at great risk and likely to benefit from receiving the resource. Third, then, would go to people who are likely to benefit, but potentially have a lower likelihood of being exposed. And if we still have anything left over after that set of prioritizations, then everyone left is roughly equal. And so it becomes ethical to apply a first come, first served system. We are not going to use social criteria to distinguish between individuals. 13, staff members should be encouraged and supported in asking difficult questions and making suggestions, and must be assured that they will not face retaliation even if issues arise that they raise cause discomfort. In other words, all staff should be asking difficult questions, and they shouldn't be silenced or retaliated against for bringing up ideas or asking for clarification. 14, staff should receive education about the specific guidelines for practice that will be employed during a pandemic and the exemptions to current protocols that will be allowed. And finally, additional ethics consults should be requested as new issues developed that are not addressed in this document. That is, we need to recognize that ethical issues will arise that go beyond the scope of what we've discussed here right now, and the Ethics Committee is available to help with those decisions. I'm going to leave my PowerPoint now and get back into the Adobe Connect to see if there are questions. Julianne, is there anything for us to discuss, or have we exhausted our time?
I don't think other people can hear me, Doctor, so you need to repeat the question, I believe.
Okay, and do you want to keep going?
Yes.
Okay, go ahead.
In this question, thank you, Dr. Gillette. So we have a question. Could you explain what demonstrably high risk factors or high risk family situation means in terms of making exemptions for?
Yes, it's an excellent question. And in the more detailed version of that ethics report, and I do have some of the more detailed stuff in probably in a form that I could share. We want to recognize that as a general rule, everybody should be considered essential, and you don't get a pass because, say, you have children. However, there could be circumstances where your risk of contagion actually creates what I would say is a clinically demonstrable risk. So you have a loved one at home who's immunosuppressed, and it's going to be very, very difficult. And there's no one else to take care of them. I mean, the first thing you might consider is, do you need to get a hotel room? Does the hospital need to create housing for staff members who cannot go home because they can't be taking a risk of bringing contagion home to their homes? But there could be situations where you have people who depend on you and will not get the support they need if not from you. And there is a greater than background risk of contagion. That is, it's not the risk that all of us will face in the midst of a pandemic, but it is a demonstrably higher version of that risk. That could be you if you're immunosuppressed. It could be a dependent family member who, frankly, has no one else that they can depend on. What we said in our ethics report is that it's not for the ethics committee to define all those standards. That would be an overreach because those are very pragmatic organizational decisions that need to be made. We said in our ethics report that that decision needs to be made on a supervisory level and that the facility should create some sort of standard that the supervisors will apply when they make their supervisory decisions. So the ethics committee can't tell you what that policy should be. We can only tell you that we believe it is ethical to make targeted exemptions from a requirement to come to work once you, on the supervisory level, put a standard in place so that you can explain why one person is required to come to work while another person is not. I hope that answers the question.
Great. Thank you, Dr. Gillette. Here's a second question regarding PPE and from professionals to patients. Non-healthcare citizens.
Get a little closer to your microphone there, Julianne.
Sorry. If non-healthcare citizens hoard the necessary PPE, does that change the provider's relationship to patients? If the hospital can provide PPE, does that change the relationship between providers and patients?
Fantastic question. So the question here has to do with if citizens out in the world hoard up the resources, say the N95 masks, what does that do? Does that change the nature of, say, the provider-recipient relationship, a healthcare provider's responsibility to patients? And if a facility is not able to provide appropriate PPE, does that also change the relationship of the provider to the patient? Fantastic questions. And I think that some of what I've said should give us some answers to this. The first part of the question, I think, has to do with those voluntary risks to health. Is it true that an individual can be held morally responsible for choices they make such that they have a lower claim on health care? Now, the problem here is that the first half of the question, I think, is impossible to apply on an individual basis. So you're never going to know if I'm the one who hoarded up the masks such that you don't have them now. In any way, have I forfeited my right to care because you can't get proper protection? We're never going to be able to apply that appropriately or accurately, which means that actually this question is not two questions, it's one question. It's all the second question. If the healthcare provider doesn't have enough PPE to go around, then does that change the provider's moral responsibility to continue to provide services or the types of services that they provide to a patient? In other words, I don't believe it makes any ethical difference at this point whether the shortage that the organization is facing is because citizens hoarded up resources that they shouldn't have, or the federal government didn't get the tests out fast enough, or I don't know, private companies are jacking up prices, or everybody did everything right and we just ended up with a shortage because we just didn't have enough. In other words, I don't believe that any of those factors will change the substantive question that's being asked, which is, if you run out of N95 masks, does that change your moral responsibility to continue to provide services? The best answer that I can give you is based on the analogies that I provided, and that's why I provided those analogies. I do believe that as healthcare providers, you have a moral responsibility to go to work even if that's risky. I do believe that you can be asked to do things that do carry some inherent risks that frankly we're all uncomfortable with. I also believe there's a point at which your employer can no longer demand that you do certain things without any supports whatsoever. Like sending a police officer out without without a bulletproof vest, or telling a firefighter you have to run into that building, or telling a home healthcare worker you need to get in the middle of a shootout in order to provide home health. It's hard to know where to draw that line, but I would probably say this. In disaster circumstances, just as the standard of care with regard to the doctor-patient relationship changes, such that patients can no longer expect as much from their doctors. In a true disaster, the disaster arete kicks in. Your elective procedures are not going to happen. Even procedures that are not elective but can be put off are going to be put off. Normally, you could gripe about that, but while we've got people dying on vents, you can't. That's the whole concept of a graceful degradation of the standard of care, a new standard of care that comes into place. And just as patients have to learn to expect less from providers, so too employees may have to learn to expect less from their employers. I believe that if your hospital runs out of N95 masks, they may have to tell you to use surgical masks. I don't know that a healthcare provider can say, hell no, won't do it. When you run out of all masks, surgical masks included, at that point, we may see such a breakdown of the healthcare system that it may actually become ethical for a healthcare provider to say, now you're asking me to run into a burning building. I can't do it. If I do it, then I'm going to put myself at such risk. It's not even a selfish thing where I don't want to get sick. Now it's going to be, if I get terribly ill, I won't be able to help anybody else. So that would be the point at which you'd have to say, we are now going to have to get into some heavy-duty rationing, not even rationing of ventilators, not even rationing of N95 masks, but now groupings of patients who are COVID negative, who are going to be seen by COVID negative doctors, and those COVID negative doctors are not going to be anywhere near even a suspected COVID positive patient, because without PPE, we're going to lose them all. It's a complex answer to a very, very good question. And I guess in summary, I would just have to say, you can't expect as much protection from the hospital as you could have yesterday. The hospital will have a right to tell you to put yourself in harm's way. There will be a limit to that demand, however, and at that point, you will be able to say, we've reached that limit. Defining what that limit looks like is precisely what I'm arguing for in disaster ethics as an altered standard of care. The hospital needs to write a policy that says, we believe we can demand A, B, and C from our providers. We do not believe that we can demand X, Y, and Z. As long as we're getting A, B, and C done, we're going to keep chugging. We hit X, Y, and Z, we're going to have to reconvene and figure something else out. Julianne, any other questions?
Yes, and Dr. Gillette, you're the only person who can hear me. So when you speak,
Yes.
If you could rephrase a question. The CDC has said that if you run out of masks, we're to use bandanas or scarves. Is that running into a burning building?
I love that question. The question is, if the CDC has now said if you run out of N95, use surgical masks. If you run out of surgical masks, use bandanas or scarves. And the question is that the moral equivalent of asking someone to run into a burning building? I can't answer that specifically, because I'm not a clinician who can answer this question. So I will give you a conditional response. If wearing a bandana is as good as wearing nothing, then you're at the point of running into a burning building. And we need to have a serious conversation about whether or not we're going to switch to a voluntary situation of providers who are willing to take that risk, because maybe they feel that they're young and healthy enough that they could easily survive infection, and they don't have dependents, and so they're willing to take that risk. But that then would become an option. It would be morally permissible for people to do it, but it would not be morally obligatory. On the other hand, if wearing a bandana is like wearing a surgical mask, then I would argue that that's good enough. It's not ideal. It's not what we would have done if it weren't for this pandemic, but it falls within the reasonable bounds of a facility altering its standard of care to response to the disaster. So I can't actually say yes or no about a bandana unless I know whether or not the bandana is as good as a surgical mask, in which case I would say do it, or if it's as good as nothing, or clearly less effective as, say, a surgical mask, in which case I would say we have now crossed that ethical boundary and we need to be talking about voluntary participation as opposed to compelled participation. And I'm hopeful there'll be enough healthcare providers who would even take that voluntary risk that we could still get the job done.